Okay, let's go on this case. So 56-year-old female, past medical history relevant for hypertension, hyperlipidemia, type 2 diabetes, class 3 obesity. So she's a 300-pound patient, not uncommon in Tennessee. You know, we are like the home for hot chicken, right? So that's every other patient there in Nashville. So BMI of 50 and chest pain with moderate exertion. So again, this was like 0.4 millimeter slices. Okay, so this was done at a photon counting CT. Still, the images are not beautiful. This is a patient with very high BMI. And we can check, you know, here, and we can MIP it. And we're going to go over that. So as we MIP it, it was like, oh, she doesn't have much calcium. There's a little bit of calcium here. Very minimal calcifications, right? And we go over like the LAD. The LAD kind of wraps around. And then we have like, you know, the RCA. And the RCA, you know, it's a dominant RCA, but there's not much plaque. So there's not much going on here. And then we have like, you know, the circ here. Another thing, this is a technical issue here. You can see that the right side looks brighter than the left side, right? So this is a problem with the contrast of the injection, with the timing of the injection, right? We time the injection, we put a region of interest at, you know, the aorta, right? So the left side is opacified, but in this case, you know, it looks like a CTPE, right? A P protocol. So there was a problem here, you know, but still, if we, and you just have, you know, just take my word for that. If we put a region of interest at the left main, you're going to have like, you know, at least like 350 household units, okay? So it's a diagnostic scan. So that's why we ended up not giving more contrast, you know, this patient, okay? So again, nothing super exciting here, right? And look at this. So now let's take a look at the thin slices. And now let's take a look at the LAD. So I'm going to get the left main. I'm going to put this like, you know, on top of the left main. So what I do here is two longs. So a long axis here, a long axis here. So two long axes, you know, give me a short axis. So I have a short axis now off the left main over here. And this short axis, you know, I can see the left main coming. Oh, something happened here. And then it appears again. What is that? So this is the left main, and then, whoops, right? One thing, you know, that we can do here is, yeah. So what I'm doing here is I got a cross section, and this is like the smallest area of the left main, and I'm getting a cross section. That's the minimal looming area, or MLA, for our interventionalist. So the MLA here,
this is a 1.3 millimeter.
Yeah, it's very small, okay? So again, this is not a great test. The patient is having some chest pain. Again, you could take this patient directly to the cath lab. However, you know, the patient was very afraid of going to the cath lab. You know, we even send that, and you can see like, you know, over here, once again, this is very concerning. Next year, this course might not happen, might just be like RoadMap, you know, because RoadMap also picked it up. We call it moderate, you know, but moderate more than 50% at the left main, that's very severe. And that's a CAD-RADS 4B, because 4B is 3-vessel disease with severe, or left main with more than 50%. And then we have the FFR, and we have like a huge translutional pressure drop, you know, here at the left main. The left main FFR is sometimes there is a lot of issues. It's like 60% of the time works, 6% of the time works all the time, right? There might be some issues with the left main FFR. But what we decided to do here, and that's why I wanted to show you this case, is because the patient didn't want to undergo a cath. And we have to prove that this is like, you know, severe. So we did a PET. And here you can see the stress on the top. The bottom is the rest. We did ammonia, N13 ammonia. And we can see that the EF dropped from 68 to 57%. That's one of the things. Also, the end-diastolic volume, increased. So there's like, some transient ischemic dilation, right? This is the ungated images. You have a huge area, here of decreased perfusion, right? Pretty much it spares the RCA territory. But all of this big area here, that is like the left main territory, it's down. And compared to the rest, it's all reversible. This huge area of ischemia. Here we have the flows. In the flows, remember that we did the translesional pressure drop. Here, you see the flow on the top, it's like 1.7 and down to like 1.4. If you divide, the apical anterior by the basal anterior, 1.4 divided by 1.7, I'm going to get roughly 0.79. That's a flow drop. But that's what my other mentor, Dr. Marcelo Di Carli, he called this PET-FFR. So there is a basal to apical gradient over there. There is a basal to apical drop over there. And again, the stress flows, they are all reduced 1.6. The flow reserve, the myocardial flow reserve is reduced. Basal to apical gradient, over there, right? So that's, again, left main, disease. So this patient was referred for, this is a cath. She ended up getting a cath. RCA is fine. Left main, you can see here, right? And the other thing is that you can see that there are some collaterals, right? A lot of collaterals, right to left collaterals. So this patient ended up undergoing CABG. And okay, so the bottom line here is that sometimes coronary CTA is great, but sometimes, some patients, especially like very obese, stents and all of that stuff, functional testing is good as too, okay? Not coronary CTA is great, but, each patient, needs what the circumstances demand, okay? Awesome.